Welcome to the Better You Project, optimizing health hormones and aesthetics. And today I have an extremely special guest, someone that I've admired for a very long time in the functional medicine world, who is actually a surgeon in that she's doing all the things for breast implant illness syndrome for women's health. As someone who is a huge advocate for women's health and getting to root cause, she is someone that I very much highly regard and refer quite a few patients to when they suspect this condition is on the horizon. So I welcome Dr. Christine Kelley. I'm going to give a little bit of a bio on her, so I'll be the hype person here for just a second. So she began her medical education at the University of Missouri in Kansas City. She received a bachelor's in biology and chemistry in 1985, and then finished medical school after a 6-year program, correct?
That is correct.
Okay, perfect. And then
it's a unique program where you earn a BA and an MD in 6 years.
Okay, perfect. And then she chose a career, so general surgery first, was chief resident at the University of Kansas in Wichita, earning the George Massio Award for Surgical Excellence. She then transitioned to plastic surgery and completed training at St. Louis University in 1991 through 1993, where she served also as the administrative chief resident. She has served in the U.S. Air Force at Scott Air Force Base, achieving the rank of major and earning an Air Force Commendation Medal, honorably discharged in 1996. Then she shifted gears and was certified through the American Board of Plastic Surgery in 1996, and then started practicing in Indianapolis in 1999 at Meridian Plastic Surgery, where she currently practices. So welcome, Dr. Kelley.
Thank you. Thank you for all of those kind comments, and thank you for your invitation today.
Absolutely. Absolutely. So let's talk a little bit, Dr. Kelley, on what brought you to the service of plastic surgery.
Well, as you indicated, our training starts in general surgery, and then you decide if you would like to subspecialize. And aspects of plastic surgery that I found very attractive included, I would say, the fact that there are many options to approach a problem in plastic surgery. It's not so much a cookie cutter approach to a problem. Of course, it can be, but there are many situations where we get to consider the pros and cons of different strategies. And I found that I really enjoyed educating patients and helping them, guiding them through that decision-making process. I also like the fact that from an anatomic perspective, plastic surgeons are trained and certified essentially to work from the scalp down to the toes and to the fingers. So that's really kind of cool. And then similarly, there's a broad range of changes that plastic surgeons can.
Yeah, absolutely. Oh no, I think I lost. Can you hear me okay?
I can hear you. Can you hear me?
Yes. Yeah. Okay. Sorry for a second cut out, and I'll edit that. I'm writing down the moment. Okay. So let's talk a little bit about how you got into breast implant illness syndrome. So if we refer to BII, that's what we're referring to as a condition called breast implant illness syndrome. So what brought you to that particular disease process?
I would say, as with anything, just some synchronies in a way. A patient from Australia has written a book some time ago about her experience with very severe systemic reactions to breast implants. It was a very difficult story to read, and she had sent that book to the practice. And I read it, and I found it interesting and concerning. For some perspective, I started practice at the time, or really was training in plastic surgery about the time that the first implant, we'll call it controversy, the controversy regarding whether or not breast implants are safe in the late 80s and early 90s. And throughout my career, of course, I've read a lot of reassuring studies about the safety of breast implants. And that is generally, or has been, the perspective of my specialty, and even internal medicine, like the Institute of Internal Medicine published a very influential manuscript or review. But despite that experience, I always felt like it was plausible that breast implants could cause systemic reactions. I was open-minded to it, in other words. And I felt like maybe we just needed more time, different methodology to identify that this was in fact happening. So I think it started with open-mindedness. Then the daughter of an existing patient of mine came to see me and asked me to remove her implants for breast implant illness concern. And at that point, it starts to get real, right? And I'm a little bit nervous about, should I really do this, because the literature doesn't support this. And yet my thought process was, she had the autonomy to insert the implants. She certainly had the right to ask them to be removed. And I was very careful to advise her as to what our current understanding was at that time, and I could offer her no guarantees as to an outcome. But she did well. And then somehow a second patient came in, and she was actually challenging soft tissue issues. She did have another indication for explant, which was a fully deflated saline implant. She was very lax. She appreciated the efforts that I went to give her reasonable appearing breasts with a simultaneous lift. And she was the patient that really started it for me, because she was someone that got on social media and was my bullhorn. And then more and more patients came in, and each time consistently, they would report significant symptom improvements following implant removal. And so my experience supported my open-minded perspective. And I continue to support those patients in their desire to remove their implants.
Yeah, no, that's amazing. That's amazing. As someone who also kind of goes against the grain, it's kind of scary stepping out there and just kind of being a little bit of the oddball. But what's so reassuring, and I can tell as you're saying this, is that it's that patient vindication that you're doing you're onto something here. You're doing something good. And I think that is what fuels us as healthcare professionals, our passion to, all right, well, let's dig a little deeper. Like, I mastered that. Like, how can I help this and make it even better? So I think that's really important to kind of note there.
That's exactly right. And I tend to be more cautious and conservative and wait until things are well proven. So this has been an uncomfortable place for me to be relative to my personality and my usual approach to things. And yet these women weren't finding the help anyplace else. And I've been very reassured by their positive responses to my approach and to the treatment. And that does keep me going and encourages me to dig deeper, just like you said.
Yeah, kind of makes it okay then to be different, right? Yeah. I can completely understand that and appreciate that for sure. So let's talk a little bit about, you had mentioned the kind of the patient cases that you had. What would you say are your typical presenting symptoms of BII in a patient where you would start suspecting those things?
The symptoms are nonspecific, and of course that makes this very difficult to study. And that may be one reason that we have been where we are with this issue over the last 20 or 30 years. And they are typically attributed to either chronic inflammation, or they look like autoimmune disease or chronic fatigue syndrome. So it is very... The most commonly reported symptoms are fatigue, brain fog, joint pain, muscle pain, skin rashes. Dryness symptoms can also be prominent, such as dry skin, dry hair, dry mouth, dry eye. Hair loss is commonly reported. A fair number of these patients also have gastrointestinal symptomatology. I'd say at a minimum bloating, although many of them suffer from chronic constipation or diarrhea as well. Reflux is common. And then there's a little different spin on the symptoms. Some are more neurologically oriented. There were some concerns in the 90s regarding breast implants and multiple sclerosis, for instance. So there are patients who describe tingling, weakness, dizziness, migraine headaches, things along those lines.
Yeah, absolutely. So what's so interesting is you name all those symptoms, and I'm like, well, that looks like Sjogren's, that can look like Hashimoto's, that can look like lupus, that can look like celiac
Exactly.
disease. It can look, it's like the great imitator. It can look like Lyme, mold, Epstein-Barr. I mean, it looks like everything. And so I think that's where, unfortunately, medicine 2.0, which is more reactive. Well, let's just wait until like you present, like you got it positive. It's like, well, what can we do to like proactively not get there, and how do we dig a little deeper to get to that conclusion? So, which brings me to my next question, like, how the heck do we diagnose this? And so when I have patients who come to me, because a lot of times they're coming with these very vague symptoms, when you diagnose hypertension, it's like, oh, your blood pressure is high and we've got so many readings on that, it's like, okay, we've got that. But with this, because it's so vague, and a lot of times it's symptom report, it's so hard to diagnose, right? So when you're doing a workup and you suspect this, like, are there any like blood tests you would recommend? Are there any other diagnostics that you recommend running or that you run yourself before you start having that explant conversation?
You are correct. It's considered a diagnosis of exclusion. And currently, there are no diagnostic criteria in terms of grading or rating the symptoms. There is some work actively underway to provide a grading system that might help us have a diagnosis in that regard. There are no consistent laboratory tests. There's no imaging that is particularly helpful either. Imaging, you're looking for rupture, perhaps silicone granulomas, but that is not consistently correlated with this disease either. So in terms of how I approach diagnosis, I have a detailed symptom inventory that I developed. I did an exhaustive search of what patients had reported as possible symptomatology associated with this condition. And initially, I was just using that qualitatively to help me keep track of their symptoms and to really see how many that they had. When I started doing research with Dr. Sinha at IU, he recommended, from a data collection perspective, we need this quantitative. So that form is currently graded from 1, meaning essentially no type of symptom in that category, to 5, which is very frequent or very severe. And that has been very helpful. I use that form if I'm looking at a woman with breast implants and she has grade 4 or 5 symptoms in many categories, particularly the ones that are commonly described by clinicians. What are people telling them? Of fatigue, brain fog, the muscle joint, skin rashes, and then add in the dryness symptoms, then I'm pretty suspicious. In terms of any blood work or testing that I recommend, many of these patients see me because they've already gone through that testing. They report to me that it's been normal. They're frustrated that their provider has not found anything. I typically do not recommend additional testing. I feel like they have lab fatigue. And many times that testing, it is negative. It doesn't really get us anywhere. Maybe this isn't the correct perspective, but I feel like if they are a good surgical candidate and they desire to have their implants removed, we have a conversation about the fact that breast implant illness remains controversial, that we don't know the etiology of it. We can't really diagnose it. But if they're comfortable proceeding, then I feel like the explant process actually becomes a test, so to speak, in and of itself. So I can send them off to have some very expensive specialty testing. Or if they want that implant removed, we take that out. And of course, from a temporal perspective, timing wise, if they improve on the back end, that's suggestive that the presence of the implant was related. Now, there are concerns of the nocebo effect, that it's purely response to. I don't really share that concern. I think we're looking more at physiology. But I certainly understand how psychology can be involved in this situation. There is some element of it. Getting breast implants, having breast implants, deciding to remove breast implants, certainly has many psychological aspects as well.
Yeah, absolutely. Absolutely. So I think this brings up another good question. So, when I have a patient who suspects that they had BII, obviously I'm not the guru. I'll say, hey, why don't you go see Dr. Kelley? But in the meantime, what are the testing modalities I can do to help rule things out? And not only that, but to prepare the detox system in their body for surgery. So I have a patient actually recently who just took out her implants, and I had put her on some great amino acids, just some natural stuff, making sure she's eliminating. So making sure she's on a good probiotic, some magnesium at night that can kind of help rid of the toxins. And not only that, when you undergo surgery, kind of like things go to sleep for a second, and then, detoxing the medications that are required to put people asleep.
Exactly.
Glutathione is another thing that I will use a lot. So glutathione, I would say, is like the master antioxidant. So these are like putting more garbage trucks in the system to like get things out. And then I have a really kind of unique protocol that I will do for patients after explant on the natural side to kind of help their body heal a little bit quicker. But you're absolutely right. It's kind of like let's see if this works. And if it works, then it's probably it. And there's just not as much research yet. And so right now that I think is very reassuring in that when they do get better, you're like, well, that was the only thing we changed, So I think it's an exciting time for sure in medicine. What's difficult though, is because there is not like a specific ICD-10 code that we can bill for insurance, the question becomes,
Yes.
well, will my insurance cover this? And so that's a question I get. And I kind of tell them, unfortunately, probably not, because it's not something that they can link disease process to, level of service and this. It's like I have to rule everything else out. And there's just not a lot of facts yet for insurances to validate that this is a thing. You see it because you have that clinical experience. They haven't gotten the memo yet. So typically insurance does not cover an explant surgery.
That is correct for all the reasons you said. This is not an accepted diagnosis yet. There's not felt to be enough evidence of its presence. It can't really be diagnosed. Insurance companies, of course, want objective criteria for a diagnosis. They're not comfortable with subjective diagnoses. So I understand the frustration of the patients on this particular question, but we just don't have enough evidence to change the policy of insurance companies at this time. It is unfortunately considered self-pay, particularly in our geographic area. There are some patients that apparently have gotten it covered in other geographical areas, but that's the interesting thing about our healthcare system. There are discrepancies based on insurance provider and geography.
Right. Yeah, absolutely. Absolutely. So kind of shifting gears a little bit, what would you say is there, a lot of times in medicine, it's pattern recognition, right? It's like, okay, I've seen this case enough. It's like if it looks like a duck and it walks like a duck, it's probably a duck kind of thing. What would you say, Dr. Kelley, is the kind of the typical pattern, or if there is a couple patterns of recognition that you suspect this? So, is there an age? Is there a like an ethnicity? Is there a BMI? Is there something that you feel like, oh, she's got this, she's got this? What do you see for patterns?
I would say the main pattern, you are correct. And I like to refer to the fact that, we live in an era where we so highly value science and evidence-based medicine, but we often cannot start there. We have to start with the problem and what it looks like and start by seeing what the pattern is. And the pattern is that symptom profile in a woman with breast implants, I would say. I've not seen any particular orientation towards age. I think many of the studies average out around, 45 in terms of the age, but I think that just reflects the broad range of age at which women undergo augmentation, and there seems to be a little bit of a time delay before the symptoms develop. I've not seen issues with a particular BMI, ethnicity, any real association with prior medical history either. it's there's not a consistent pattern that points towards potential triggers, which I know is a question you wanted to talk about.
Yeah, yeah, absolutely. So let's say, for example, if someone comes in for a breast augmentation consult and they want to put implants in, if they have a personal history of an autoimmune condition, is that like a contraindication? I already kind of know the answer, but that's not necessarily a contraindication to implants, correct?
That is correct. That is the standard. Well, it can kind of back up. It's not considered a contraindication. The contraindications are relatively brief. Active infection in the body, pregnant or breastfeeding, in the presence of cancer that's not being adequately treated. Those are the only three contraindications. Autoimmune disease or a family history of autoimmune disease can be placed on a list of precautions, things to consider, but
Right.
not considered to be an absolute contraindication against augmentation, with the justification being that we have this large body of evidence that there is no conclusive evidence that breast implants trigger autoimmune disease, and there's no evidence that implants can worsen existing autoimmune disease. And therefore, if a patient desires breast implants, I think it's reasonable to inform them of the possibility of either worsening their existing disease or if they have a family history triggering it. But that is not current standard of care in my specialty. It does not really have to be emphasized.
Right. Right. No, absolutely. So, so we do functional medicine in our practice, but I also do a fair amount of Sculptra, and Sculptra, which is polyallolactic acid. That is something that I approach Sculptra in my aesthetic patients from the functional side. And I tell them, do you have an autoimmune condition? Is it well managed? If you had a flare up, when was the last time you had a flare up? Are you on any immunologics that could potentially cause with that? And I've had patients who are, lupus, who have had Sculptra with zero issues. So it's kind of interesting. In the functional medicine world, when we talk about autoimmunity, there's this kind of like three pillars of autoimmunity, and there's usually genetic predisposition. So usually someone in the family has some sort of autoimmune condition. We may not know who it is because many years ago and barely now, I feel like they didn't really check people for it, right? So, they were like, oh yeah, Aunt Alice, she had some weird thyroid thing. We don't really know what she had, but that could be something. So there's genetic predisposition. Then there's usually some sort of triggering event. So a lot of times in women, it's like the birth of a child, the loss of a parent, maybe the change of a job. There's some sort of dramatic thing that happens to us that kind of like it heightens this cortisol response, which can kind of trigger some of that. Yes. And then the third thing that happens is gut permeability. So gut permeability, I don't like using the word leaky gut. Again, I try to be very science and evidence-based. So gut permeability is when there is some sort of little endotoxemia within the microbiome in the lining of the gut, where these little tight junctions that we have that helps absorb and digest and do all these processes in the microbiome, they don't work as well. And so then what happens is these food particulates start to come through. They allow certain overgrowth of certain bacteria. And that's what I kind of see in my world is that some of my patients who have had these explants, I've gone back to look to see on their patterns of their GI map. And to my dismay, there's not a particular pattern. Like I've got some that have got candida. I've got some that have overgrowth of staph aureus and strep. I've got some that have SIBO. It's just, there's not a particular pattern. As much as I was really hoping for it, there's not. But maybe in the future, Dr. Lee, you and I can put our research heads together and say like, okay, well, what is it? Is there one thing on all of these cases that we could really dig into to say like, okay, this is the common variant. So, but there isn't at this time. And that's kind of what I look at is we always say, 90% of the immune system is actually made in the gut. And so if I have someone who, has these types of symptoms, again, they're very subjective, they're very vague. I say, well, let's try to focus on rebuilding the microbiome and see if your symptoms get better. And so usually when I take them through my kind of rigmarole of tests and labs and functional tests, it's usually I start with a good serum panel. And that serum panel has things like a high sensitivity C-reactive protein. I'm looking at inflammatory markers. I'm looking at SED rates. I'm looking at CBC, CMP. I look at TPO antibodies because autoimmune Hashimoto's is the most common autoimmune condition we have in the United States, and it's more common in women. So that, I mean, we have the same population at this point. We're living the same avatars.
That's right.
The other thing is that when you have one autoimmune condition, you are 40% more likely to have another autoimmune condition. So it's kind of like when you find one, you're probably going to have some friends in there. So those are the people for me on who does that person look like? Those are the people that I'm looking for, and we start ruling things out. The other thing is that, I'll say, okay, well, let's clean up the diet. Let's try to switch to a whole real foods diet, eliminate a lot of the processed stuff, specifically gluten. There was some work by a researcher named Alessio Fasana, and he talks about this concept called molecular mimicry. And what that means is that when people consume gluten, it triggers this autoimmune kind of response where their body is going to attack whatever it thinks. So I always say Hashimoto's disease is an autoimmune condition that's manifesting in the thyroid. If you look at celiac disease, it's an autoimmune condition that's manifesting in the gut, or psoriasis, it's autoimmune that's manifesting on the skin. So what do we have to work on is the underlying root cause, which is autoimmunity. So I think it's really, really interesting to try to approach it from nutrition, lifestyle, gut health, good supplementation if that's what they need, and trying to get their body back to base. And then if all those things work, again, it's a process of exclusion. It's like, all right, well, let's start looking a little deeper into some of these other things. So I think it's really important to know that this is not like, when you take a pregnancy test, you're like, you're either pregnant or you're not. It's not that simple. It's a lot more invasive. And I think it's really important for people who suspect they may have this condition is that it's a bit of a workup. It's not cut and dry. It's not cut and dry. So I think it's really, really important. The other thing that I wanted to ask is when you're doing, so you're in the OR, you're doing the operation, you're doing the explant, you're removing the capsule. Let's talk a little bit about what does that capsule look like and what does the implant look like?
I'm going to say you're getting a little unstable, and I don't know if that's you or me. I missed a fair amount of what you just went through, and I'm so sorry.
Oh, that's okay. That's okay. I know the screen's a little bit fuzzy here for a second. I don't know if we lost a little blip of the connection. So I went through, now you're clear. Okay. So I went through what I see in autoimmunity, and then how do I approach it from the autoimmune perspective? Because again, this diagnosis, like many autoimmunities, is we have to focus on the core of good nutrition, good sleep, eliminating alcohol, minimizing gluten, removing a lot of those inflammatory triggers that we see within the body that the body does not like, and trying to get it back restored to like homeostasis kind of thing. Right. So I've done my work with them, and I've sent them on to Dr. Kelley. Okay, so Dr. Kelley, you're in the OR. You've done your workup. You're in the OR. What do you see on the capsule, and what do you see on the implant?
This is interesting where we talked about patterns earlier, and I think that I do see some patterns associated with breast implant illness patients, but I don't have any evidence or way to understand what I'm seeing necessarily. I would say that a key observation is hypervascularity. The capsules of breast implant illness patients have very fine blood vessels growing through them. They tend to have a pinkish red hue, whereas implant patients where I'm doing procedures going back into that pocket for non-BII reasons, it tends to be avascular. So I would say that's a consistent observation in the breast implant illness patients. Not always present, but to a high degree. I do occasionally, but I'd say a moderate to say 50 to 75% degree, we'll see a tannish film on the implant surface. I have discussed this with Dr. Sinha at IU, and he's told me it's hard to know what that is. I do take careful swabs of that. We do PCR and NGS testing for bacteria and fungus, and it does not consistently come back positive. So it's not necessarily a bacterial biofilm. He thinks that it could be the white cells producing proteases and destroying protein and creating a slime that represents damaged protein. I have also fairly consistently observed, I tend to call it acrid. The closest thing I would say, it's almost like vinegar, but not quite odor. And I've come across some reading recently, just really trying to look at, what might happen to the silicone on a chemical basis. Some forms of silicone, when they degrade, can produce acetic acid. So I wonder if that's what I'm smelling. I'm not really sure. That's completely theoretical. But those are some of the observations that I can tell you about.
Yeah.
I will also note, if it's okay, that so many patients fear that they have mold in their implants. They've seen the terrible pictures on the internet, particularly those patients with saline implants. I understand, but I've only seen that grossly twice, and probably maybe 10 times on the fungal analysis with the PCR and NGS. So, and other busy explant surgeons have said the same thing. We tend not to see it grossly. That doesn't mean that mold isn't part of this picture. I have another colleague that I work with. She is looking at the majority of the patients she's evaluated, IgG and IgE evidence of mycotoxins. So mold seems to be a common problem that women with breast implants have developed. How much of that is responsible for the symptoms we're seeing? We don't know. But it does not appear that it's commonly found in the space. It's more that the body seems to be at immune disadvantage in terms of clearing the mold. That's the thought.
Interesting. Okay. No, that's super fascinating. So when you send things out for biopsy and testing, is there one commonality that you've seen with any of them?
No, not to a consistent degree, meaning that pathology will often just say chronic fibrous capsule, even though to the naked eye, I felt like there was some inflammation manifest by vascularity. Sometimes, though, the pathologist will identify chronic inflammation and point out specific cell types like giant cells reacting to foreign body. Similarly, the microgen testing that we do for bacteria and fungus is not consistently positive. In the research that Dr. Sinha is doing, he has higher quality specimens to analyze. So he's seeing that probably, I think he's told me about 70% of the time he can find evidence of biofilms in the patients reporting BII symptoms. So that's fairly high, but it's still not in the 90 to 100% range.
Yeah. No, that's super interesting. Okay. Let's see. Next question would be, what does the post-op time, what does that care look like? Are there specific recommendations you have from a post-op perspective as far as you recommend these things afterward? Because I do, and I'll tell you what mine are, but I want you to go first.
From a recovery perspective, I would actually try to reassure patients that it's a multimodal analgesia and a long-term Marcaine block that really helps the pain that this has a reputation for producing. In terms of supplementation, I tend to recommend collagen and or amino acids, vitamin C, and sometimes the DFH products, SPM Supreme, I find that to be helpful in concept. I am noticing that by putting patients on these products, they are healing to scar, durable, strong scar, much faster than I used to see previously in my practice. So that's an observation before using these types of products and after. But otherwise, I have not dabbled in that too much. But again, networking with others, I think that it's important to make sure that vitamin B and vitamin D levels are normalized. Magnesium is normalized. I think on a nutrient level. And
Absolutely.
you may include that in your protocol, but I would really love to know what you're doing.
Yeah, absolutely. So just as you said, I actually like to set the system good. So I try to make sure that they're on a really good probiotic prior to surgery. And so usually a broad-based probiotic, something that has lactobacillus acidophilus, bifidobacterium, those are all really good. DFH is Designs for Health. So if you're a listener and you're like, did she say DFH? That's Designs for Health. So that's it. It's a great medical grade nutraceutical company, and they've got so many really good blends of integrative type supplements that we use. And so I know Dr. Kelley uses that. We also use whole body collagen as well. The probiotic is great. The vitamin D is absolutely essential because we live in the Midwest. Most people walk around very deficient in it. So that's great for the immune system. The other thing is B Supreme. So B Supreme has methylated B vitamins. It's got P5P in there. So methylation, the way I describe it to patients, it's kind of like you're putting a plug in an outlet and the spark plug. It's what triggers the next step in a system called methylation, right? So it helps with kind of processes run. And what B vitamins, especially B12, what that does is it provides ATP to the mitochondria of the cells. And so when we talk about a lot of these issues like mold and Epstein-Barr's, a lot of those are mitochondrial issues that can lead to things like brain fog and fatigue. And I just don't feel good. I got this joint pain. So really high dose B vitamins are going to be absolutely essential for that. The other thing that I will do, just as we talked about, was that amino detox. I love amino detox. And so a lot of times I will have them do that post-operatively. And I typically recommend like 2 capsules twice a day. And the amino detox has many of the essential amino acids. So just as we talked about, kind of like the spark plug, amino acids are building blocks of different processes. And so they help as cofactors. So it's kind of like giving the car the gas to then get from, point A to point B. That's what amino acids are doing, and they do it for a lot of different processes in the body. The other thing that amino detox also has is something in there called L-glutamine. We talked a little bit about, I think it might have been when the call got cut out a little bit, but we talked about gut permeability. And so what L-glutamine does is it helps kind of patch up some of those little holes in the microbiome that can help prevent that endotoxemia that can happen, where it's kind of like the stuff in the gut is kind of getting everywhere in the system. It's like, no, we need to get that contained. So I think that's super helpful. The other thing that amino detox has in there is something in there called calcium diglucarate. Calcium diglucarate is it's a nutrient that helps with phase 2 to phase 3 detoxification when we talk about hormone metabolites. So phase 1 to phase 2 can be really kind of a process where it's kind of like we're taking all the toxins and we're putting it in the gut. Phase 2 to phase 3 is like, all right, now we're gonna get it out of the trap door kind of thing. And so calcium diglucarate is amazing for that, because when people undergo surgery and you have sedation and anesthesia and pain management, your bowels can slow down. And so calcium diglucarate is another little nutrient in that amino detox that I think is super, super helpful. I think those are all really, really good ones. Another thing that we will do in our practice is something called, again, very controversial, IV ozone therapy. So IV ozone is it's kind of like giving the body a very small hermetic stress. So hormesis is kind of this idea where you're giving a little bit of stress to allow the body to kind of trigger a cascade of different healing processes to kind of heal itself from within. So we utilize this type of procedure in peak performance people who struggle with brain fog, the long haulers post-COVID, people with autoimmune conditions. And what it does is it can really help with reducing oxidative stress in the body, and it can help with supporting and strengthening the mitochondria of the cell. So it's a great one. And that's usually, I will do one IV once a week for 3 weeks, kind of right after they're able to kind of get to the office. And then a lot of times after that, I will pair it with a glutathione IV push in their IV. And glutathione is the master antioxidant. So it's kind of like, again, releasing more garbage trucks in the system to kind of remove the trash out. So I think that can be super helpful. So vitamin D, B Supreme, amino detox, IV ozone, IV glutathione, and then making sure that they're eliminating. So making sure that they're having bowel movements regularly.
Absolutely.
all really, really, really helpful to kind of get everything out, kind of thing. So that's typically what I do and recommend for that. So and those are all, very well tolerated procedures and supplements that we do. And I think it's important to work with someone who's familiar with how to use these supplements, because what I can't stand, and I'm sure you get this in some of what you do, is patients come in like, well, I listened to the Joe Rogan podcast and they said I should take this, that, and the other. I'm like, have you checked your blood work, or have you done any tests to actually see that's what you need? And so I think doing this, and I do check I do check serum glutathione levels, and I do check high sensitivity C-reactive proteins, and I do check a marker called GGT, which I would say that's a marker of total toxin burden in the body. So I can kind of see, like, do I need to up the glutathione dose, or actually you're doing okay, so I'm just going to kind of give you more of a moderate dose of it. So yeah, it's kind of fun, kind of being a little bit of a cowboy, isn't it?
Yeah, I share that frustration that you have, though. Patients, they particularly read things on the breast implant illness social media websites about how to detox, and they have no data, they have no labs,
Right.
And then they might come in for their visits and say, "Well, I'm actually feeling worse. I think I'm detoxing." I'm like, "Yeah, you're detoxing blindly, and you may be doing it too quickly."
Right.
I really prefer that they work with a provider like you who can get them set up with some testing, know what the data points are, have experience about what's gentle, what is more going to be a more severe approach to detox, and give them good guidance.
Yeah.
I do also understand their financial limitations and concerns, but I encourage them that if they're going to go down that pathway, either do it in very simple, safe, gentle ways like you've just described, or if they want to be a little bit more aggressive, see an experienced provider. I think at the end of the day, if you're doing it blindly, kind of wandering around the forest, not knowing where you're going to spend more time, money, and maybe even cause yourself some harm.
Absolutely.
Better to see someone who can give you a good prescription.
Absolutely. Especially looking at things like kidney function and liver function, because it's like, I would say liver is like your body's garbage disposal. And if that's not working, like you're putting a lot of stuff in there, and it is going to get clogged, and you're going to have an overflow, and it's not good. Some of the other things, so I mentioned a lot of our good supplements, IVs, all those things. Some of the natural things that don't cost a lot of money that people can do at home are things like red light therapy. So red light therapy can be super supportive to the mitochondria. It can also be really good for scars. It can also help with kind of just that detox system in general. I love recommending things like Epsom salt soaks. So just sitting in a warm bathtub, putting some Epsom salt in there, and that can kind of help pull out some of those toxins. Another thing is like making sure that they're taking time off and making sure that they're resting. I think we as women in particular, we're always on the go. We're successful, we're moms, we're grandmas, we're sisters, we're doing all the things. It's like, whoa, you need to slow down to recover. And I think sometimes just sitting a patient down, like, you need to stop before your body stops you, because it's going to. I think that's really helpful. I think using things like natural antioxidants. So my favorite one is green tea. Like, you can get green tea anywhere, and green tea has an enzyme in there called EGCG, which is a great detoxificant. So I think that's super helpful. We talked about sleep. Oh, dry brushing. You can get dry brushing off of like a little dry brush off Amazon after you get out of the shower, before you get out of the shower, and after. And dry brushing can be super helpful. Castor oil packs is something that I recommend a lot for my patients who need help with especially estrogen metabolite detoxing. Mm-hmm. You get that off Amazon, and that's where you put little castor oil on this like cloth, and you put it over the liver before you go to bed, and it can actually help some of that detox pathway. And I would say my most easiest one is lemon water. People are like, lemon water? I'm like, yes, lemon water, because lemon water can also be a great way to flush out those cells. So we went from like bougie, most expensive protocol to like basic stuff. And I think honestly, a good mix of both is really helpful for the patient as well. So wow, I'm looking at my notes. Oh, I did have one question that I thought about it later. What do you recommend when patients decide, do I put implants then back into my body? Am I better suited for like a fat transfer? Like, what are your thoughts on that, Dr. Kelley?
Interestingly, I have only had a couple of patients consider reaugmentation because of their frustrations with their body appearance. And they have improved symptomatically. But they were, again, it's a pro and con, right? They're balancing benefits versus the potential cost of the implant, and they know what they're getting into. Only one of the two actually reaugmented. And as far as I know, has not had any symptoms that reached a threshold at which her sense of vitality has been so impacted that she would elect to remove them again. I think that there is a thought out there, and maybe need to be something that we could look at and prove that there's something about the implant. It's degrading, it's releasing chemicals, or a biofilm is developed. Can you clean out the space, put in a new implant, and restart for some unknown period of time that gives you more life with the enhancement of a breast implant? Possibly. The majority of my patients don't even go there. I mean, I will sometimes have patients that are frustrated with the flatness of their outcomes because that's naturally how they are. Of course, I need to bring up the option of reinserting implants, although neither the patient or I are really interested in going back down that road. Fat transfer. So fat transfer is actually a tool that I do like to use. I understand that there are concerns. Two of the primary concerns would be, sometimes patients say it doesn't work. Well, we are limited with that technique. We know that not all of the transfer fat is going to survive. I think that's due to a combination of factors, including the fact that we remove the fat through liposuction. We're traumatizing some of those fat cells. They are going to die. Then the fat cells in the recipient site need to become vascularized to survive. That doesn't reliably happen. So that's a known issue that we can't overcome at this point in time. There is research trying to increase the amount of long-term viability. I think we will get there, but we're not there yet. But that doesn't mean that you don't use the tool, because you get 60% with a new processing device called Viality, 80% it looks like retention. Would you rather be there or at 0% correction of an indent deformity or reaugmentation? The second concern is that fat can store toxins. And are we releasing that through liposuction, through fat transfer? I understand that concern, but it's interesting to me. I see no patterns in terms of patients that I have treated with fat transfer, and they're feeling more lousy on the back end.
Yeah.
I do understand it as a concern. As a practical concern, is there something bad happening? I'm not necessarily observing it. I would love your input. I think if we support them with all the things that you've described in drainage, we can help mitigate those concerns to a certain extent. But I'm aware of a study that showed with bariatric surgery, toxins being released. They actually measured it in a small number of patients. So I get it. But again, what else am I going to do in those patients? We would prefer not to reinsert implants. I don't have any other way to increase their size or improve indentations other than fat transfer, or referring them for sophisticated flaps that are used for mastectomy reconstruction, which I would think would have similar concerns regarding sophistication of the surgery, complications of the surgery. You are cutting into fat planes. You're probably releasing some toxins with those procedures as well.
Yeah. No, absolutely. I completely agree with you when we talked about the endotoxemia. So think about our semaglutide patients that I'm helping them lose weight. I'm helping them lose weight.
Mm-hmm.
I'm asking them, like, are you pooping every day? Are you drinking your water? Because I need to make sure that they are detoxing, because I can't tell you how many people we get to lose weight and then they get a gallbladder attack, or all of a sudden they don't feel good, or all of a sudden their hair is falling out. And it's like, okay, well, we got to sift through all of this. What is happening? And that's why it kills me that there are so many of these little pop-up semaglutide places, because I'm like, ew, there's so much going on in there that if you're not equipped to handle it and all the like downstream effects that we see,
yes,
you're going to do more harm than good, So, what is the new, or is there a latest recommendation as far as how often should women get implants changed out?
There really is not a formal recommendation. I think patients amongst themselves, again, on the social media sites, are referring to about 10 to 12 years.
Yeah.
I think I have not found a data basis for that or a factual basis. What I have found is surgeons and patients arguing that the longest FDA safety studies are 10 years in length. I think that that is really kind of a soft indicator insofar as those 10-year studies had very poor follow-up. I mean, often somewhere around 25 to 30% of patients showing up at 10 years. And if we're talking about an implant safety issue and we're referring to data that has caused the FDA to say, well, these devices are safe, I'm not sure that using that data to determine when we should remove and replace implants is helpful.
Yeah.
There is some information that as you exceed 10 years, your statistical likelihood of your implant being silently failed, unknown to you, is definitely increasing. It's an older study, but a plastic surgeon how many of his implants 15 years and replace them, and it was 70%. So I think currently plastic surgeons are telling patients to have an expectation, but not necessarily a recommendation to remove and replace every 10 to 15 years. It has that somewhat complicated issue. On the one hand, what I tell my patients, if you don't feel like you're symptomatic, either locally in the breast environment or systemically, and your breasts still look and feel in a way that you would like, maintain that investment and don't undergo another surgery, which has anesthetic exposures, risks, and cost. However, I think patients that are becoming symptomatic, well, I mean, we may get to the point where we come up with strategies to allow them to keep their implants longer, but I think that then becomes more of a conversation, not just for remove and replace, but explant. From an expectation standpoint, so patients understand the implants are not lifelong devices, though, I tend to tell them, anticipate that you will have some issue, some evidence, such as mammographic evidence of rupture, ultrasound evidence of rupture, that would indicate another procedure in the 10 to 15 time range.
That's good to know. I feel like that's a question I get asked because I do all the women's health and when's your mammogram? Oh, you have to get a diagnostic. And then they tell me, oh, my implants are due to be changed out. And I respond with, I don't know if that's the recommendation. And I've talked to my own medical director who is who also does breast augmentation.
Yes.
And he was saying, Lexi, I feel like if they're not, kind of like what you said, if they're not giving the patient problems, why would we cause more trauma to a patient if they look fine aesthetically, they're not causing any issues, because there's risks with surgery.
Exactly.
And which is surprising. It's so good to hear from you and from him, because you guys are both surgeons, right? And so it's like, it's kind of like, well, if it's not causing a problem, do we really need to operate, versus over eagerness. So that's good. That's really, really good.
Yeah, I just don't think there's enough evidence to prescribe a specific time frame to remove and replace your implant.
Yeah.
I understand there's concerns that with time, exposure to warmth, body fluids, white blood cells, the implant is degrading and it might be releasing materials. But women breath enough that one procedure to go in. If they're doing well, I tell them I don't really subscribe to that theory. I would like to undergo imaging to make sure the device is not ruptured. I really am not comfortable with the idea of leaving ruptured implants in, because I know the outcome of that is very severe local inflammation, which I suspect spills over systemically.
Absolutely. Yeah. Agreed. Where, if a patient suspects or if a patient would like more information about BII, where do you feel like is the most reputable source where they can find that information for them to kind of read on their own?
Well, the classically known website is the Breast Implant Illness and Healing by Nicole. I think it probably close to 200,000 members there. But it's so large that there is some misinformation there, and patients can get lost down rabbit holes.
Sure.
We do have a local Indianapolis breast implant illness support group that is much smaller, a little over 100 members. I think you can get good information by asking questions there, and it's much harder to get lost. Interestingly, I find that the breastcancer.org website has a very nice, up-to-date section on breast implant illness. I think that information is balanced and nuanced. I network with a colleague in functional medicine who has extensive experience in breast implant illness, Danielle Valoris. She is a physician assistant. Are you familiar with Danielle?
Erin was just telling me about her. She said that she needed to connect her and I.
I think that would be awesome. I think you have very similar approaches. She recently started a website where she offers testing. Now, this would be redundant to people here locally, I think, because you are perfectly capable of doing these things. And you've described a process, a perspective that's very similar to hers. I think she's over in North Carolina.
Yeah.
But she actually has a how to optimize post-explant support group on Facebook, where there are educational meetings that she's providing for those subscribers, going through some concepts for detoxification and recovery. And I think that membership is only $25 a month. It's very inexpensive. Nice. Danielle is a powerhouse in the BII space. She is responsible for increasing patient awareness. She provides excellent education. In fact, she, with another very potent woman, Terry Diaz, has established an online conference called the Breast Implant Health Summit. She brings together eminent scientists and clinicians every 2 years to discuss breast implant illness. It's an excellent conference, and it will be in November this year. She is starting the first time this year, a similar online conference for patients to discuss recovery, and that will be in August. She's been responsible for advocacy with the FDA. She's actively treating these patients and trying to develop protocols. She, I think I referred to earlier, is currently looking at mycotoxins. So she has a mycotoxin study, and anyone who's willing to participate, interested in participating, go to her website, and your how to do that is on that website. And so her website is NavWellRx. I find her an excellent and very helpful resource.
Yeah, I'm bookmarking everything that you're saying right now so I can make sure I reference back to that later. It's good. It's good. All right, Dr. Kelley. Well, I think I got to ask all the questions I've been dying to ask you, which is so good to finally get to connect on a podcast and get some good content out for patients. I know the audio was probably shoddy in and out, so I'm going to do my best with editing and trying to make sure that it is seamless. But definitely, I'm sure we could have you on again for, probably in the later fall to kind of where are we at now with the BII. So it's so good. Do you have any final closing thoughts for listeners, patients, practitioners, anything at all?
Well, I'm sorry about the audio, and hopefully it's not my connection that's causing that issue. There's some sort of instability here, but so I apologize if it's on my end. Maybe I should be on Ethernet, well, not Wi-Fi. I don't know.
That's okay.
But final thoughts would be that even though I'm concerned that there does appear to be systemic reactions, autoimmune-like triggering from breast implants, I don't like that this is happening to women, but I also feel like we're in an exciting time where there has been a lot of conversation, discussion, literature review, clinical series published, research definitely being done. This is an exciting time in terms of finding answers, finding ways to support women. And I think we're hopeful that maybe we can potentially being a functional medicine provider, you might say, no, there's no way, but potentially allow women to come up with a treatment regimen where they don't have to explant. They can maintain the enhancement that the implants provide, whether it's through further engineering of the implants, nutritional support, antibiotic or antifungal support. I'm not sure what it looks like, but it's an exciting time for BII. I think that there is a promising future in terms of diagnosis, insurance coverage, maybe preventing the surgical trauma of explant in recovery.
Yeah, absolutely. And for surgeons like yourself who are actually actively treating these patients and doing the research and doing the publications, like you're doing all the hard work. And so I do think it's possible. I think probably combining all the things, from just as you said, and on the functional side of it too, I think it's very exciting and it's kind of cool to go against the grain and kind of see those outcomes. So I thank you so much for joining us on the podcast. I hope to have you on again. This will be recorded. It'll be on our YouTube channel, and I will link all of your contacts as far as website and some of the other websites you mentioned in the post, and it'll be on Apple as well as Spotify.
Thank you very much.